as we gather. It's 4:01, and so I'm going to let people continue to gather, but we'll go ahead and open in prayer. And then I'll introduce Dr. Shan to those of you who may not know her. I know quite a few of you do know her or have taken classes with her. But let's start with prayer, and then we'll go from there. So the Lord be with you.
And also with you.
Holy God, we give thanks that you are a God who calls us together, to connects us in community, and that you meet us in all ways, especially through technology, that we are gathered now in your name and that you are in our midst. We hold before you those who are suffering this day, especially from COVID, from the tragedy and grief of a loved one, and all those things that are pressing in on us, the concerns bearing down on us, Lord. We offer those to your mercy and care and keeping, that in this time, in this space, we may turn our attention fully to the present moment. We give thanks for Dr. Shan, for her wisdom and her faithfulness. Pray for this conversation, Lord, that you would guide our conversation, correct it where necessary, and that we would be drawn more closely to truth, to your wisdom, your grace, and your love. Abide with us, Lord. It is in your name that we pray. Amen. Well, I'm so glad to be with all of you this afternoon and to have this time with Dr. Shand. Dr. Shand, as many of you may know who've had her classes, is a physician, a clinical ethicist, and theologian whose areas of practice include pediatric blood disorders and cancer, blood disorder research, moral distress mitigation in healthcare and ethical issues and surrounding health disparities. She's the Associate Professor of Pediatrics, Medical Humanities, and Bioethics at the University of Rochester Medical Center and teaches on the adjunct faculty at Colgate Rochester Crozier Divinity School. Her most recent course at CRCDS in the fall of 2020, she co-taught with the Reverend Dr. Melanie Dugo-May, which was on the pandemic, political ecology, theology, and responses of the faithful. Dr. Shan is going to share current information about COVID-19 pandemic issues, including vaccination and supporting parish leaders to making faithful decisions. I'm very grateful to Dr. Shan for being with us and bringing her expertise both of science, medicine, and theology together for us today. And I'm really grateful, Dr. Shan. So I turn it over to you.
Thank you so much, Bishop. And I am just incredibly humbled and grateful to be here before you. I am going to share my screen in a minute. Going to really start with some information about COVID and about vaccination. I will let you know what I know and what I don't know. So, I will lead by saying I am not an expert on the particulars of the vaccine rollout through New York State. I can talk a lot about vaccines, why they work the way they do, and sort of the process, and some of the issues that would be pertinent to you as faith leaders, as congregants and community members come to you with questions, whether they're moral dilemmas, whether they're larger issues. And so you will find me to be very honest about what I know, what I don't know, and where I can direct you to information that might help answer questions. Because as I mentioned to folks earlier, I think one of the most striking lessons we're learning as we navigate this pandemic is just the profound humility with which we must face the evolution of information as it comes. Certainly as a physician, we have been brought to our knees in the care of patients with COVID. And I speak also on behalf of my colleagues in critical care and emergency medicine. This is unlike anything any of us have ever encountered before, but it also represents a profound opportunity to think hard and critically and faithfully about what is being revealed to us at this time and how we as a faithful community move forward. So a bit about myself. Again, I'm a trained by specialty. I'm a pediatrician, trained in the treatment of children with blood disorders and cancer. Did most of my training in Buffalo and Rochester, did my oncology training at the Johns Hopkins Hospital in Baltimore, Maryland, and additional research in immunology, actually, at the National Cancer Institute. So it's fascinating to me to see this technology, to see mRNA vaccine technology, which actually has been around for 30 years in cancer research, come to this place. But I will tell you, there is something about attending to the bedside of children with critical illness, and particularly children dying of cancer, that brought me very, very close to God, and brought me through my own journey of the integration of my own faith, my own formation, and things that I really felt were missing in clinical practice. And so that's how my journey at Colgate Rochester Crozier began. The blessing of knowing some of the folks on this call, my brother John Rohde and Chuck Stewart and others. Hi, Chuck. So wonderful to see you all. Hi, John. And so I come to you as a medical professional, as faithful, but as someone who's really thinking about, if we think back about our lectionary recently, how do we come down from this mountain? Much has been revealed to us during the pandemic. How do we come down from the mountain with our hearts full, our hearts informed, with the right information, but also open and humble about how to move forward and how to serve the isolation, the challenges of this unprecedented time. And so with that, I'm going to share my screen. So we'll talk a bit about what we know. Feel free, I will reroute myself if I get too medical or too sciencey, which is always a possibility. So I'll talk a bit about what we know about COVID, what we know about vaccination, and a bit about the different vaccines. And then really focusing our discussion on faithful response and questions. I wanted to mention, certainly we're going to monitor the chat. As I go through some of the more informational points, I would just ask that questions are held until that point is done. And then folks are going to help with chat monitoring. And please be assured there will be plenty of time for question and answer afterwards. And then I'll also loop back and make sure that if there were any unanswered questions, that I can go through the diocese leadership to either point you in the right directions or make sure those questions are answered. So COVID-19, for those of you who are scientifically inclined, this picture is a wee little electron micrograph of a COVID virus attaching to a lung, which they certainly like to do. So COVID-19, the disease, is caused, as you know, by the SARS-CoV-2 virus. And I think what's really humbling, if everyone could just make sure you're muted, what's really humbling about this disease is just how much of the human body it can affect. So this is primarily transmitted by respiratory droplets. We know that for transmission to occur, folks need to be in some proximity to each other for 10 to 15 minutes unmasked. There's really interesting data about what happens when 2 people are masked versus 1 person versus another person versus no people. No people is not good. Both people masked is very good. But this is primarily a respiratory disease. But the insidious thing about it is it affects other parts of the body. and in some ways catastrophically for those who get very sick, effects on blood clotting, effects on the heart, effects on the nervous system. And in my own area of expertise, a rare consequence in children, which we're actually seeing more of, which represents an inflammatory response to the virus that can happen in kids who maybe just had minimal symptoms to begin with, or didn't even know they were infected. So we're learning more about the consequences of infection every day. So one of the take-home points I want to make for this group, and sort of how we can support our congregants and our faith communities, is that it is important to be able to direct people to reliable sources of information, because there's a lot of misinformation out there. And I say that to you not because I'm part of any sort of scientific agenda, but just because it's frightening to me as a medical professional to see how much misinformation is out there. And it's understandable that having that much information and misinformation can cause people to become more anxious, more confused, and make it more difficult for folks to discern what is right for them, for their families, or for their congregants. And so I will provide these slides. I think it's important checking the New York State COVID dashboard, where COVID rates and information are reported. There's also a vaccine tracker that can sort of let you know how vaccine doses are being delivered and given across the state. This is really the first time the state or the country has been in this kind of situation to distribute a vaccine, and it has not been without its bumps. And so staying up to date with the most current information. As you know, the United States has crossed a dubious threshold of well over 500,000 deaths from COVID-19, getting up close to 600,000 deaths. Fortunately, in I'm in Monroe County. You all are in other counties. We are seeing the case positivity rate drop from the second surge that we saw around the holiday season, and that certainly has been good news for hospital systems. But this medical professional is telling you that we're certainly not out of the woods in any way, shape, or form. The intensive care unit at the hospital I work at, Strong Memorial Hospital, is still full. We have 37 intubated COVID patients, so patients on mechanical ventilators as of today. We still have 4 different medical units, sort of services, as it were, dealing with COVID patients. We still have adult COVID patients in the children's hospital because there's no place else for them to go. So it is still very much a reality for our daily lives and healthcare system. Again, other resources, the Centers for Disease Control. The Centers for Disease Control is a reliable source of COVID information. Unfortunately, the CDC got ensnared in the politicization, I hope I never have to use that word again, of COVID information dissemination. That was my New Year's prayer, that vaccines would never have to be politicized again, but getting some thumbs up there. But the CDC is a reliable source of data. The Johns Hopkins COVID dashboard, full disclosure, I'm a Johns Hopkins grad. I got my master's in viral immunology from the Johns Hopkins School of Public Health, but they've got global COVID data. It's really cool. Like my kids love it. You can look and see how the case positivity rates are around the world. Unfortunately, the US doesn't look so good compared to our neighbors. National Institutes of Health, and of course, the World Health Organization. So as we begin to frame our conversation around COVID and faithful response, I would be very remiss if I didn't mention COVID-19 and its impact, its amplification on health disparities. And so we know from data in New York State, New York City, and beyond, that a largely disproportionate number of persons of African American, Caribbean American, Latinx, and Indigenous persons are disproportionately dying of COVID. And there are many questions about why that is. And there are many answers to why that is. Delays in getting to healthcare, delays in getting to testing, the strains on public versus private hospital systems, the plight of undocumented and migrant workers, public health infrastructure in Indigenous communities. So many answers, but the data is very clear that there is a disproportionate death impact on communities of color. And the restrictions and the strains on the healthcare system that COVID has imposed has led to a substantial worsening of healthcare access for other chronic conditions in marginalized populations. I have to tell you, as an oncologist, I am petrified about the next 2 to 3 years. I'm petrified because we know that Black women are 3 times as likely to 5 times as likely to die of breast cancer because of delays in getting to mammography. And I'm really scared about undiagnosed breast cancer and undiagnosed colon cancer due to barriers, slowdowns, weakening infrastructure in the healthcare system. At the beginning of the pandemic, we talked a lot about what if there's a twindemic of COVID and influenza? What are we going to do? Well, I have to tell you, my goodness, if you look at New York State influenza data, wow, now we know what to do to prevent influenza, and it's wear masks, because there's basically, I don't want to say no influenza in the community, but there's very, very little influenza in the community, which is great. I'm glad we don't have to deal with that right now. But the real twindemic that I'm sure all of you are acutely aware of in your ministerial setting is the mental health crisis, isolation, depression, anxiety, and with that, an exponential rise in drug overdoses and substance abuse, addiction struggles during this time of isolation, during this time of many public health safety nets falling apart. My clinic population is mostly children and largely adolescents and young adults in the city of Rochester. The impact of not having been at school, where the counselors are, where medication administration can be relied upon, has really been, it's been overwhelming. And so as we frame faithful response to COVID-19, yes, we need to talk about whether it's safe to gather for services and what the church can do or support in terms of vaccination. But we really need to think about the big picture of the unveiling and entrenchment of health disparities. Right, so vaccines, how do vaccines work? I'm not going to get at this is for your reference, of course, but I think it's important to know a lot of questions I get from communities about vaccines. People hear genetic, they hear mRNA, and they get worried, right? Is this thing messing with my DNA? What are the long-term effects of this? What could possibly happen over the long term were I to get a gene-based or a genetic-based vaccine? And what I want to share with you is just the fact, some reassurance, and just really cool stuff about the science. Full disclosure, I have no stake in any pharma companies whatsoever. Pediatricians are notoriously the worst compensated in medicine, and we're all just fine with that because we don't care. But so how these vaccines work are really actually quite brilliant. And it requires some understanding of how the immune system works. And suffice it to say, all those crazy pictures of the coronavirus, the crown, those little jewels on the crown is something called the spike protein. And that spike protein is what makes corona look like corona in the pictures. And it's what makes it stick to tissues and get into the lungs. And so what the vaccine does is it delivers a message a message to your body's immune system cells, not the rest of your body, not your DNA, but it delivers instructions for your immune cells about how your immune cells can make a tiny part of that spike protein and present that tiny part of the spike protein to their friends, other cells in the immune system, and say, hey, if you see this little tiny thing that's part of a spike protein, you know that this is coronavirus. So you better jump into action and get this thing cleared out of the system. So the mRNA technology is just what gives the immune cells the message, the machinery to make that little part of the spike protein themselves so they can tell other immune cells, hey guys, here's what it looks like. So if you ever see it again, be prepared to gobble it up and clear it out of the system. The mRNA vaccine does not integrate into anyone's DNA. It does not predispose to other mutations forming. It just gives immune cells that little bit of information that they need to know to make an educated immune response. So the two vaccines that are out there, Pfizer, Moderna. Now there's Johnson & Johnson. We'll get to that because everyone's like, oh, one vaccine instead of two. Oh my gosh, one is always better than two, or is it? So Pfizer and Moderna, the vaccines are essentially identical. And so they both use this RNA, this technology, this messaging technology. Both need 2 injections. Both are really effective. So any vaccine efficacy that's like effectiveness that looks like 85 or 90% and above at preventing SARS-CoV-2 or COVID-19 infection, that's really good. And the big difference between the two, the biggest difference between Pfizer and Moderna is that pesky storage issue. There's something about the Pfizer that it has to be stored at lower temperatures. And that's just important because when you think about how do we deliver this, right? If we're going to load up the van and go downtown and immunize at the dome, how are we going to preserve the vaccine and keep the active parts active? And Moderna, you have a little more flexibility because it doesn't have to be kept at those cold temperatures. The actual molecular difference between the two vaccines is really pretty negligible. The message about the spike protein to educate the immune system is exactly the same. The only thing that's different is it uses these little lipid particles. It's genius to get the vaccine into the cells, and the composition of those little lipid particles is slightly different. That's the only difference between the two vaccines. Everything else about them is exactly the same. And so those are the real differences that freezer, how they have to be preserved. And again, it's related to the lipid particle delivery system, the envelope, as you will, that the vaccine is packaged in, but not what it does or how it does it. So you might ask, like, well, why 2 doses, right? What's the story with that? And that all has to do with how immunologic memory works. And I am not going to bore you with a lecture on CD8 T cell memory. If you want that, I'm happy to do it another time, but it's probably not what anybody wants or needs today. But essentially, your immune system needs a little reminder. It needs that first exposure to the protein. Your immune cells say, hey, if you see this little thing, this spike protein, that's bad, and you need to clear it out. And your immune system gives that message to like a core population of T cells that are going to then go and kind of sit in reserve and wait to see if that coronavirus comes around again. If you give a second dose of vaccine a few weeks later, you ensure that there's even more educated T cells that are sitting in that reserve ready to go. And so we call this the prime and boost mechanism of immunologic memory. And it's not new. Most childhood vaccines require a dose and a booster. If you wait too long to get or you don't know when your last tetanus was, and you end up seeing my husband in the emergency room because you stepped on something and he's got to put a whole bunch of stitches in your foot, he's going to give you a tetanus vaccine if you don't know when you got your last one, just to make sure. We're learning that measles, your immunity sometimes can wane later in life if people get titers and you need a little boost. So we know that this is a prime and boost. So 2 doses apart. For some people, you might have heard, some people experience those reactogenic, we call them, side effects from the vaccine a little bit more after the 2nd dose. And that actually makes perfect sense to an immunologist because your immune system is getting educated. So fevers, muscle aches, chills, that's your immune system kind of getting revved up, not too revved up, but just revved up to know enough to know, hey, I know what to do if I get infected with this virus in the future. And so I tell people having a fever after the 1st or 2nd is not necessarily a bad thing. Having some muscle aches and pains, that means your immune system is doing what it needs to do. It'll go away after a few days, but it's not a bad thing. And it's a heck of a lot better than getting COVID. So you might ask, okay, thank you for that primer on 1 dose and 1 boost, appreciate it. So what's the story with this Johnson & Johnson vaccine, and why can we really get away with just 1 dose? So here's what we know about J&J. It's a single dose vaccine. It's made differently. So I told you about Pfizer and Moderna, that little bit of message genetic material that's packaged in the lipid nanoparticle. This actually uses a different, something called a virus vector. And so the delivery of the information that the immune system needs to know is different. And it looks like from their research that 85% of people in the study getting this vaccine were prevented from severe COVID disease, and a good proportion, over half, from moderate disease. And so the FDA said, that looks pretty good. We're still getting data. We can proceed with a use authorization. Now you might say, well, 85% doesn't sound as good as 95% for Moderna. But it's tough because these studies were all done at different times and the effectiveness criteria aren't all the same. So I wouldn't say that you're comparing apples and oranges, but you may be comparing like clementines and tangelos as it goes for those differences. One question that has come up, if anyone has read the news the past few days about Johnson & Johnson, is that some bishops, and particularly some of the Catholic bishops, are raising moral objections to the use, particularly of the Johnson & Johnson vaccine, because some of the research was done on stem cells that may have been derived from fetal tissue, either from abortions or from infertility clinics, like if an embryo didn't take. And we'll get back to that and that moral objection issue, and some of what the science is later. But some of you who read the news today, I felt it would be remiss of me to talk about the Johnson & Johnson vaccine without bringing up the fact that these objections are being raised by some. Certainly medical experts feel that if anyone is offered a vaccine and is able to get access to a vaccine, that they should take whichever vaccine is available, so that we can get some herd immunity. But I would be remiss if I didn't mention that for further discussion if anybody feels that that's necessary. So another question, all right, folks are getting vaccinated. Okay, we're impressive, right? 95%, you say, 90%, great. Do I have to wear a mask after I get vaccinated, 3 weeks after I get vaccinated, right? Then what's the point of wearing a mask? Why do we have to wear masks? Can we gather? What do we need to do to get back to normal? Is the vaccine going to fix everything in a short amount of time? And so what I'm going to present to you is what global medical experts say at this point. I present it without judgment, only that these are the facts as we know them, and happy to discuss that further. So a question that comes up, well, who and how many people in the population would we need to immunize in order to have some confidence that there's what public health experts call herd immunity? right? So maybe not everyone in the population is immunized or has immunity, but enough people have that we can really drive down disease transmission and again, protect vulnerable populations. This isn't just about me. This isn't just about you. This is ensuring that we protect the least of these, those who are most vulnerable among us, those with chronic diseases, those who are elderly, those who we think are more likely to die from COVID. And so the answer to that is, at this point, we don't know. We don't have that magic number. It's probably different for different places in the country. And unfortunately, the targets keep moving, right? What's going to happen in Texas now that they've lifted the mask mandate? Let's pray for all of our brothers and sisters working at the big hospitals in Houston, because they're actually already overtaxed. When's it going to be safe to gather for religious observances? And when I say safe, safe with social distancing, without social distancing, when can the choir sing again? And the answer at this point is gatherings have been able to be safe if they're adhering to current recommendations about masking and social distancing. But it's very hard to know at this point when it will be safe to do that without the recommended masking and social distancing. And we're gonna have to be humble and patient in the face of evolving data as we watch community transmission go down, as we watch case positivity go down. But unfortunately, the availability of vaccine doesn't mean that we can take our masks off and return to life as we hope it will soon be. We're probably going to have to be patient for a little longer. All right, if we're vaccinated, why do I still wear a mask? I got my second dose of Pfizer on January 6th with a second cohort of essential workers at Strong Hospital. Why do I still wear a mask? I still wear a mask because, as confident as I am in the preliminary data that there's protective immunity, we are fairly confident that that protective immunity lasts, but we haven't had enough follow-up. We don't know for sure how long. And so I feel like it's my duty, until we know that, to protect the vulnerable people in my life and the vulnerable people that I work with. And so I think that we are going to continue to recommend that folks wear masks even after vaccination, until community transmission gets to a sustained low level. What will that level be? I don't know, but we will continue to follow data and know. And until we feel confident that enough vulnerable persons have been able to be vaccinated. And so to close this part, when we think about faithful response, questions for consideration, how do we adapt, or do we adapt, right? Our gatherings, our sacraments for the present circumstances. The question that in my religious life and in my congregation, so I'm a longtime catechist for second graders. So, such pressing theological questions as, are we really going to drink Jesus's blood? But a lot of conversations about how our celebrations happening, how our gatherings happening. Do we adapt? How do we adapt? And I think that larger question again of, in our ministry to the marginalized, in our ministry to the least of these, as we come down from the mountain, how do we define and redefine our mission as a church to those in need, to fit the circumstances of COVID? And is adherence to hoping that things will be the way they were before serving that mission? Or how do we adapt? How do we continue our ministry to communities that are marginalized by COVID? Either by having a place for kids to access internet, for example, who are not in school. How do we support mental health crisis, social isolation, particularly for the elderly? How do we collaborate to help level some of these disparities, and how can we help make sure that information that our congregants, our brothers and sisters in faith are referring to and taking in are accurate and are helping ease the anxiety, the profound anxiety and uncertainty that everyone is experiencing. And so those are certainly not all the questions about faithful response, but some to generate discussion. And so at this point, I'm going to close the didactic part of this and open up for questions, for discussion. I know we have some in the chat, and just very happy to get some more conversation going. Thank you so much.
Dr. Shand, thank you very much for that. And folks can add questions in the chat. We have a couple there and a couple we received in advance. Two questions related that might be helpful with your ministry or your service with children as a pediatrician. What do we know about vaccination for children and possible timelines about that? And then in a more church context, as a pediatrician, what's your perspective on children's programming at church?
So with respect to, I'll start with the easy one, which is children's programming at church. And I think that what our experience so far in terms of schools that are open is that it's abundantly clear that with proper masking and social distancing and health screening in place, there is not meaningful COVID transmission happening in the schools. And I think that's important. But again, I always have to clarify the schools that are open. And there's a disparity in which schools are open and which schools are closed. And I can only speak to Rochester because that's where I live. Rochester City Public Schools are essentially still closed. We've got some in-person learning happening. We're pushing, our pediatricians, we are pushing real hard to get our schools open because of the larger health implications for our patients not being in school. But what we do know is that if masking, social distancing, and basic hand washing, we are kind of learning that unlike some other viruses, it's important to decontaminate surfaces sort of generally. But the real concern with coronavirus is respiratory droplet exchange through speaking, through singing, for children through yelling, through enthusiastic, children are full of the Holy Spirit and we do not want to discourage that. And as such, it is best for children to wear masks. But in situations where children are masked and there's social distancing in place, we can follow the lead of the public schools and know that, and even follow some of the recommendations from New York State about schools opening, and know that with those precautions in place, it does not appear that student-student or student-teacher or teacher-student transmission is happening in a meaningful way. The kids who are testing positive in the schools are testing positive because of family exposures or exposures at other activities. Now that may raise the question for younger child programming, because there are some, it's hard for, let's say, 4-year-olds to keep their masks on. But I have to say, and I'm biased as an oncologist, my patients always have to wear masks all the time, even before COVID, right? Their moms were not going to take them to the grocery store if they didn't have a mask on because they're getting chemo and their immune systems are suppressed. So I think kids have a lot less problems keeping masks on than adults do, but that may just be the pediatrician in me talking. In terms of pediatrics and vaccination, at this point, Pfizer and Moderna have been doing clinical trials for children ages 12 through 17. And we do know that where we're seeing more transmission happening is with our friends who are in high school and college who like to congregate. And what's gone on college campuses. And college campuses are just a recipe for disaster as far as those things are concerned. And I'm not placing blame on the young adults. That's just the young adult brain. And so I think that vaccination may be available for that age of kids, 12 to 17, as early as the summer. Whether vaccination is going to be a criteria for school reopening without, precautions, I think is unknown and probably a bit of a stretch. But I think if vaccines are going to be available to young people, the target is that 12 to 17 population. Trials are ongoing. Can't provide the vaccine unless the studies have been done. And this is my area of expertise, gosh, it's hard to recruit kids for clinical trials. And there are ethics involved in that as well. For kids ages 0 to 12, studies are just starting to open. And I think there's some questions about how important is it for the younger kids to be vaccinated. And at this point, we just don't know. So that's what I can tell you about kids and vaccination. And so someone asked what type of ventilation is recommended for classes for children in the churches. I think what's more important than air movement in the room is that children wear masks and they sit 6 feet apart. And actually the most important thing is masks. The second most important thing is health screening. And health screening is a pain in the butt, because spring pollen is upon us and every kid is going to have a runny nose, but every kid with a runny nose needs to stay home. And I will say, 75% of what I do in my telehealth practice is, Jack ate tacos for lunch and threw up in gym class. So he got sent home because that's a potential COVID symptom and he can't come back until he gets a COVID test. And the reality is that's what we need to do to keep the schools open. So health screening, making sure that kids don't have symptoms or fever on the day of participation, and there's masks and social distancing. If it's possible to have a window open, that's great. More air movement is always better. When it's nice outside, if it's possible to be outside, that's fantastic. But really the most important things are masks, 6 feet apart, and health screening prior to the activity.
That's very helpful. Thank you. And on the same token, because there was a question about ventilation more generally, would you say that applies that many churches in this diocese don't have the ability to open windows or doors? And so what about
so I'll tell you, the
general
classroom where I teach second grade faith formation, I was just there last night. It's the basement where youth group is. And the reason we picked that room, so we couldn't pick classrooms that are already used at the church school, because then there would it would interfere with their cleaning policy. And so I'm teaching faith formation. So what we did with our faith formation, we split the second graders up into 2 cohorts. So 10 of them come every other week. The other 10 come every other week. The room that I teach in does not have windows, but it's big. And all the instruments are shoved in the back of the wall now. Their desks are 6 feet apart. They each have their own, inside their desk, they have their own pencil. They have their own workbook, which they would have had anyway. And we do temperature screening. And knock on wood, so far we've had no problems. We did pause and go to remote in the month of December because of the very significant surge spike that we had here in Monroe County. But that's how we've approached. And I'll tell you, the minute it's warm enough for me to get those kids outside, we're going to be doing our lessons outside. Someone asked if young children are not vaccinated, do vaccinated grandparents need to quarantine before seeing them in person? So I think that's a very personal decision. And it's so hard, right? Because we talk about social isolation, we talk about the importance of family connection, and the impact on grandparents of not seeing their grandchildren. And so I think that I think the biggest risk there again is from the children to the grandparents, and not vice versa. And I think that it's important for assuming that you're living in the same area and not traveling from another state, ensuring that your grandchild does not have any potential symptoms. Some families are still choosing to mask and sit 6 feet apart. Some families don't. There are no set recommendations for that. I think if a grandparent is vaccinated and the children are unvaccinated, it is safe enough to gather with them, as long as you've had a conversation with mom and dad that everybody's been feeling okay, and that we're going to use all of our usual precautions. Some people feel more comfortable with masks versus not. The safe answer is to stay distant. The realistic answer is just to keep that line of communication open about anybody having any symptoms. I think this is a really important, I want to make sure that I get to this question and the questions that relate to it, which is about return to worship. Really, really important. Thank you, Jeff Kane, for the way you worded this question. How would you approach the desire from some congregations to return to in-person worship when not everyone in New York State is eligible to be vaccinated? And even with the best intentions, right, people tend to clump together. You want to get back to that pew that you're usually in. And I agree, seeing parishes as a microcosm of disparity until the vaccine is available to all. So I think that churches are not an exception to the risks of gathering, and what I worry about, and just take this through my lens as a physician. When I think about the folks that are most wanting to get back to in-person church services, I worry there's an overrepresented a proportion of those people who are at high risk for COVID-19. And so, my feeling about that is that if there's going to be in-person worship, it needs to be within the confines of what's currently being recommended in terms of safe gathering. So in terms of distancing, in terms of masking, in terms of what percentage of folks that would typically gather in the gathering space, because we just don't know. And as you said, there are going to continue to be bumps in the vaccine rollout, disparities in who gets vaccinated, and we don't want gathering at church to be a potential source of infection. And we have seen it in our analysis, meaning New York State analysis of some of the microclusters originating in church services. So it's very, very hard, right? How do we tell people that the type of gathering that is the most meaningful to them, that may be important for their own personal theology, for their salvation, for the alleviation of distress, for grace and mercy, that we still have to wait? But I think until we have more information on how herd immunity is looking, gathering needs to be limited to whatever the public health authorities are saying is safe for that particular county and in that particular location, with those precautions in place. Someone asked me, what's the deal, in my best Seinfeld voice, with educators being apprehensive about shots? So I will tell you, my most recent town hall that I did for COVID, because I've been doing a lot of these, was with Dr. Sean Nelms, who's a superintendent of East High School, and we did a joint community conversation with school teachers in Rochester City School District. And teachers being apprehensive about vaccination. I think there's just general apprehension about vaccination. I wish that I had a coherent answer as to why folks are apprehensive about vaccination. Some are concerned about the side effects. What if I have an autoimmune condition? What if I have something that could be exacerbated by that reactogenic response, the fevers, the body aches? As a physician, my response to that is that that reactogenic response means that the vaccine is working. You might feel your arm might just be sore. You might have some fevers and aches for a day or two. You might feel cruddy for a week. But that feeling cruddy means that you are very most likely to be protected from infection with COVID over the long term. And so, it's hard to know. I think we're in an unprecedented almost circumstance of mistrust about the science, mistrust about the process. Now, these vaccines have become available to the public a lot faster than vaccines have in the past. And I think there is some public concern about, do we really know that these are safe? And I think my answer to that as a researcher and as somebody who's studied sort of vaccine and drug pipeline for a long time is, it probably shouldn't take as long as it usually does. And that I think all the stars were aligned in terms of the evolution of this technology for these particular vaccines to be able to be deployed safely in a short period of time. COVID is a really serious, and in some cases we were dealing with mass casualty situations. We're not in that kind of a scenario now. We're out of that second surge. But it's going to take a long time to build trust. But all the data and the experience thus far indicates that these vaccines are safe and they are effective.
Another question that might have been that was a little higher up is one about cold and flu cases being down, and what's your sense of whether we might see folks being willing to keep up this masking and other precautions to keep one another safe?
Yeah, so I think that's a really interesting public health question, because there are public health experts all over the country doing really cool research on COVID transmission and COVID deaths in counties in America where mask mandates are required versus not required. The most interesting study was in Kansas, where like one side of the state routinely masked and had mask mandates and the other side of the state didn't, and the COVID deaths like very well correlated with where mask mandates were happening versus not happening. I think we'll see more of that kind of data as time goes on. I hope, and again, take me with a grain of salt, as a physician and also as a pediatrician who deals in a lot of respiratory, right, strep throat. We haven't gotten, it's been a nice break for me not getting that letter home every other week about someone in your child's class is tested positive for strep throat, or the stomach bugs or the influenza, or the norovirus, all of those things. So I think, it's interesting if you traveled in Asia or you went to metropolitan US cities where there are large Asian populations, Toronto, San Francisco, Vancouver. It was not unusual pre-COVID to see folks, particularly of Asian heritage, wearing masks during the winter months. And that is because of their experience with SARS and with MERS, MERS, which is a relative of the SARS virus and actually an antecedent to SARS-CoV-2. Unfortunately, the partisan politics of masking, I think, has and sort of how masking has gotten caught up in individual freedoms versus the good of the community has made that conversation very complicated. So my answer, Patricia, is I hope until we know more about what this sort of long tail of when COVID is going to go away, I hope that wearing masks in the winter months is something that folks consider. The burden on healthcare resources of influenza, particularly ICU beds, Ventilators, depending on the strain of influenza that's prevalent in a particular year, there's a pretty decent strain on intensive care units, mechanical ventilation. That's the time of year I can tell you the emergency departments have a significant problem with what we call boarding. And boarding happens when the hospital is full. There are no available beds for admitted patients. So they have to hang out in the emergency room until a bed becomes available for them. And so my husband can tell you that in the peak of influenza season at Rochester General Hospital, there's anywhere between 50 and 70 boarded patients in the ED. I'm not making that up. You might have 100 in the waiting room, and anywhere between half and 2/3 of them are boarding, waiting for their bed upstairs. And that's a recipe for disaster. So for the sake of healthcare resources, I hope it's considered. I think it's going to be hard to convince the people who believe that masks are an infringement on individual freedoms to keep wearing masks. But I hope we can continue to share what we know about that very simple intervention.
Bishop, do we have time for one more question?
I think so. And I see Steve White's question about getting together with pods. I don't know if that, Dr. Shand, if that's been part of your answer with like grandparents and things, but just.
No, that's a great question. That actually we've been having that conversation in my family now, because we're like, my husband's vaccinated, I'm vaccinated. And a lot of people in his family have already had COVID. So we're like, with all that immunity, but so I think that the answer to that question again is contingent on, as we continue to collect data. So all of us, and I want you all to know, full disclosure, I did not get my COVID vaccine as a frontline healthcare worker, or my husband. We were actually volunteers in the Pfizer study. We got the placebo back in August because you didn't know what you got. And then we got a phone call in December that frontline workers were eligible to get unblinded. So I can tell you, we're going to continue to go every other week to get our blood drawn, et cetera, or every month to get our blood drawn. And so those who got vaccinated are going to continue to be studied to look at the robustness of their immune response. But I think, Steve, there's going to have to be some good sense of confidence that people who've been vaccinated have durable immunity to COVID-19, particularly to these new variants that are popping up, because remember, viruses unfortunately are also fearfully and wonderfully made, and they're very smart, and they mutate. It looks like the mutations to date are not affecting that spike protein, so the viruses are still work. But we're going to need to make sure that once you've been vaccinated, that immunity is durable. And number two, we're going to have to decide what level of community transmission and test positivity is low enough that the risk of that situation would be very low. So Steve, I don't think we're far from that answer. We just don't know when that is yet. And when you talk about visiting family, you'll have an additional variable of, are you visiting them in your county, in a different county, or are you going to Texas where there's no mask mandates? And that's sort of another thing to factor into this calculus of when it will be safe.
Dr. Shand, you've given us so much to think about and so much information. And I think we may have to have you come back as things develop. I'm very grateful for your time.
I'd love to come back. Yeah, sure.
Yeah. And I really appreciate, especially helping people. The thing I find the most challenging is helping people understand how to think about it. A lot of times we think about, well, I'm not afraid of catching this, but the real issue is not whether I'm afraid of catching it. It's me spreading it to someone for whom it would be disastrous. But then also what you talked about with the emergency room and the bumps about people testing, getting in the way of other people's care, asserting our own rights. And I'm really grateful for the ways you've brought that out, especially because those are conversations I know all of the clergy are having with their parishioners. We're all trying to help people understand new ways of thinking about communal health. And so I really am grateful for your attention to that, especially.
Of course. And I just wanted to say, I noticed, I know there are a few questions we didn't get to, but as you said that, someone said, even with all these precautions, and thank you so much, how can we be sure that we're not putting folks at risk? And I think what makes this so hard is that we can't be sure. We can't be 100% sure. And so we really have to sort of examine ourselves, the data, our consciences, and think, you know, what are the risks that there's never going to be zero risk. There's certainly not going to be 100% risk. You know, at this point, I think that depending on the transmission rate in your county, if folks are committed to not come to services if they have symptoms, and everything is being enforced or implemented in the way that's recommended for your county and the state, there can be some confidence, but we're never going to be 100% sure. And the same with the question about 3 feet versus 6 feet. You know, the data at this point is very clear for 6 feet. I don't know what to say about 3 feet other than, as a pediatrician and as the mother of a middle schooler and an elementary schooler who are both in hybrid school, it's very hard to keep children 6 feet apart. So
Yes.
the reality is there's probably a lot of time where they're 3 feet apart, or even not apart at all. But if they're wearing their masks, I think that helps. So
very hard to keep parishioners. Very hard to keep parishioners 3 to 6 feet apart too. So that's kind of true sometimes also. Dr. Shand, again, thank you very much. Thank you to all of you who gathered. We will be sharing the recording of this and the slides so that you can share that with your vestries. I encourage you to share this with your vestries and with your parishioners so that everyone understands what is happening and has good information, and to make this readily available to people in your communities. With that, and given the time, many blessings to you all. May God bless and keep you. I look forward to when we gather again, and may you go and be well and be blessed and be a blessing. See you soon. Thank you all.
Thanks be to God.